So we start the basics of surgery in the field of uveitis. The main role of surgery in uveitis, besides being therapeutic, is diagnostic, where we use AC paracentesis to make diagnosis, give injections, peribulbar, intraocular, and do a therapeutic vitrectomy or a retinal biopsy to make a diagnosis. So we have Dr. Kalpana Babu Murthy, who will be speaking on diagnostic, anterior chamber paracentesis, indications and technique.
Can I have a pointer, please? So good morning, all. This is the first talk of this session on procedures, and one of the important procedure which we do in uveitis is aqueous paracentesis. So basically, we remove the fluid from the anterior chamber and send it for examination. So let's look at a few cases. This is a 56-year-old diabetic with a 1-week history of recent cataract surgery, and at the end of 1 week, she develops intense fibrin like this, and even with topical steroids, the contraction is there, but it doesn't settle down very well. And if you notice carefully, along the wound there is a keratic precipitate which has developed. And so these are cases which need to be tapped, and the fluid, we normally send it for PCR to rule out infection. And if there is, usually the stain and cultures are negative, but we do send them as a routine in these cases. And this case turned out to be positive for Pseudomonas, and we were dealing with a patient with post-op endophthalmitis. This is another case, and if you see carefully, there's a lot of pigmented keratic precipitates, and these are all active. And if you look at the pupil, there is an iridoparesis which is there. Or this is another case where you have a corneal involvement with keratic precipitates along the cornea. And this is a patient with Posner-Schlossman where there is a sudden onset of increased intraocular pressure and inflammation. So when you see there are few cells and very few KPs in the anterior chamber. But what is significant in all these cases is increase in intraocular pressure. So whenever we see a condition like this with increase in intraocular pressure, it is always important for us to tap this eye and send the sample for examination, mainly to rule out viruses. This is another patient with Fuchs heterochromic iridocyclitis, which otherwise we do not do any other investigations. But if this is associated with increase in intraocular pressure, it is important to tap these eyes to look for viruses. This is one of one 70-year-old lady who came to us with corneal changes, and then there was something like a hypopyon in the anterior segment, and she had a total cataract. So we didn't know what was going on, and these are cases which you need to tap, and this turned out to be actually a lens-induced inflammation, and if you can see, these are the macrophages which were swollen with the lens material. So a lens-induced uveitis is another indication where we do tap these eyes. This is a 30-year-old male who presented with diminution of vision in the right eye of 1 year duration. And if you see carefully, there are some structures floating in the anterior segment, and there were a lot of iris changes. And on the lens also there are changes. In the posterior segment, you have something like a subretinal granuloma. And intraocular pressures were very high. And when we tapped this eye, this turned out to be a microfilaria. And a blood smear when we did, this was actually a patient with filarial infection. And these were the ocular manifestations which picked up the systemic filariasis. So the indications broadly will need to rule out infection, and the most common indications are to rule out endophthalmitis, viral infections, toxoplasma, and parasitic infections. Another important indication is if we need to rule out masquerades, and the most common or the most important being the intraocular lymphoma, where we look at the interleukin levels in the aqueous. So these are the tests which we do from the fluid which we obtain, and the most common test which we normally do is the PCR. Along with this, we also can look at the antibody synthesis, what we call as the Goldman-Whitmer coefficient, and this is quite useful in patients if you're dealing with conditions like toxoplasma and rubella, where we look at the antibody levels in the aqueous as well as in the blood. And the third thing is cytology to rule out masquerades, and flow cytometry, where we look at the interleukin levels. This is mainly for intraocular lymphoma. Ideally, the tap should be done when the disease is active. And these are the instruments which we routinely use. This is an insulin syringe for the tap. So this is a small video on how we do a tap. So we anesthetize the eye, and with an insulin syringe, which is a 30 gauge needle already attached to the syringe, you enter the eye, and you can stabilize it with a pledget from the other side with the bevel up, and then you remove the aqueous. This can be done either by pulling the plunger, or it can be done by a passive way, where you just remove the plunger and you can just use a pledget to just push in the aqueous through this. And then you put in some antibiotics, and then you patch the eye. See this eye again after about half an hour to see if the chamber is well formed. Now, this is what we routinely use in our practice, but there are different instruments and devices which have been there, and which does help in removing the aqueous from the anterior chamber. And these are innovations which are done. Basically, you want the entry to be smooth, and you want the resistance or the distance which the aqueous travels to the syringe to be also shorter. So these are the different innovations which have come in and being used for aqueous paracentesis. One is a paracentesis pipette. This is another from the Japanese, where they have done a very short needle and a plunger which is there. And this is the minim, where it is filled with saline. So you just press that, and when you release the pressure, the aqueous automatically enters the eye. Now, it is relatively a safe procedure, done in experts' hands, but you still need to be careful. Complications are very rare, and the most common is hyphema. This is a video which shows many of these cases also have new blood vessels in the angle. So when you tap the eye, because of sudden change in the pressure, you can see a bleed which is coming in. This is the Amsler's sign. So you can also have 1 day post the tap, you can see hyphema in some cases. You can see fibrin. You can have an injury to the iris tissue, especially if the anterior chamber is very shallow. You can have a lens touch. So you need to be a little careful. It's very rare. If it is done under aseptic precautions, this is very rare, but you can have a needle track abscess. Sometimes if the paracentesis is not, if the angle is not okay when you enter, you can have minor leakage from the paracentesis side. And in patients who have very high pressures, when you tap these eyes, you can have a sudden hypotony and you can have retinal hemorrhages. And this is a very, very rare complication which can occur. So to conclude, aqueous tap is the most useful procedure for diagnostic purposes, especially in conditions like uveitis, and it is very safe in experienced hands. And the procedures which we normally do when we get the fluid is microbiology, cytology, molecular analysis, antibody synthesis, flow cytometry, and we can also use this sample to save for future research purposes. Thank you very much.
Thank you, Dr. Kalpana. A small question. How much fluid should we take out, and how much is adequate for a microbiological and PCR?
Yeah, so usually in the insulin syringe, about 1 unit you can easily remove, and it doesn't cause much of a collapse in the anterior chamber as well. But if you see a lot of change and if you feel the chamber is shallowing, we could stop. The problem comes when you're dealing with, if you're sending it for viruses, and DNA and RNA viruses, then they require a larger amount of fluid. So nowadays multiplex PCRs are available, which has made it a lot more easier. But generally about a unit should be okay.
And for microbiological?
Microbiology, we always have a problem. No matter what you send, they say the sample is insufficient. So nowadays we are relying more and more on the PCR. And if possible, and whatever fluid is left, we normally send it for cytology and microbiology.
Thank you so much.
Yeah.
We have the next talk by Dr. Pooja Bansal, who will be speaking on when and how to use periocular and intraocular corticosteroid injections.
Good morning. At the outset, I would like to thank the organizers for giving me opportunity to speak in this session. So I'll be covering the basic techniques of the periocular intravitreal steroid injections, when and how to give. So persistent inflammation and cystoid macular edema secondary to uveitis are often vision threatening, and they pose a significant therapeutic challenge. Corticosteroids can be used as a mainstay for treatment of a non-infectious uveitis or can be given as an adjunct for a short course to treat the inflammation in infectious uveitis under appropriate antibiotic or antiviral or antifungal cover. So side effects of systemic steroids are well known, like Cushingoid features, hypertension, diabetes, weight gain, cataract, glaucoma and growth retardation, especially in children. So coming on to the local steroids, there are basically two routes of administration. One is the subtenon injection, that is between the tenon capsule and the sclera, and another is in the intravitreal cavity. So subtenon steroid injection, the commonly given injection is triamcinolone. Indications are basically an asymmetric or a unilateral disease with no systemic involvement, or if there is some recurrent or chronic unilateral anterior uveitis which is not responding adequately to the topical steroids, or if there is a unilateral non-infectious intermediate or posterior uveitis, a CME associated with uveitis, a post-op uveitis with cystoid macular edema, or if the patient is in general not tolerating the systemic steroids. So this is just to show where usually we give the injection, that is between the Tenon's capsule and the sclera. This is the subtenon space. Here the injection is given. The standard technique described in literature is Smith and Nozik method, where the patient is asked to look infero-nasally and the conjunctiva is lifted with forceps, and a syringe filled with 1 ml of the triamcinolone fitted with 26 gauge needle is advanced into the globe in the superior-temporal area along the curvature of the globe, and with a slight sweeping movement we have to proceed upwards to avoid globe penetration. And then the plunger is slightly withdrawn to rule out like we are not injecting the steroid into the vessel, and finally the drug is injected and the patient is then monitored for IOP and others, any sign and symptoms of the infection. But the complications, this technique can have a number of complications. The most commonly we see is a subconj hemorrhage, or there is a subconjunctival triamcinolone deposition, conjunctival chemosis at the site, and there is ptosis or subdermal fat atrophy, because almost 30 to 40% of the triamcinolone gets deposited in the anterior orbital tissue itself. With transient IOP rise, cataract progression and globe penetration can also occur. So this is one of our patients who was referred to us with an inadvertent subretinal triamcinolone injection. And the patient was given some triamcinolone injection, but the surgeon was smart enough to detect the complication and to laser immediately and demarcate the area. And when the patient came to us, we just kept her under observation, and this there was no retinal detachment, and the deposit, the TA deposit finally resolved of its own. The another method is a cannula method, or it is a safer method. I'll just demonstrate in a video. In this, it is again an OPD procedure. In this, after putting proparacaine and betadine drops and applying a speculum, you just insert, either make a nick in the superior temporal conjunctiva with the conjunctival scissors, or with the help of the stillet itself, you can make an entry into the conjunctiva. And again, with the sweeping or the rotatory movements of the cannula, you can start entering the conjunctiva, and when you reach the hub is reached till the conjunctiva, you can take out the stillet and then you can inject the medicine. So the advantage of this is that there is almost minimal chance of globe perforation, because the stillet is already out and you are giving the injection with a non-traumatic, the polytetrafluorine, the cannula. And since it is a longer length, so there are very high chances that the drug will be going as posterior as possible, having a maximum effect. So the advantages are lower rate of complications such as globe perforation, lower risk of ptosis and orbital prolapse. There is actually no disadvantage, but if in a peripheral setting, in a busy OPD, it may be a little more time consuming and maybe a little adds on a little cost because of the use of the cannula. So now coming on to the intravitreal triamcinolone injections, the indications are almost the same as of subtenon. If the patient is having intermediate uveitis or CME which is not responding to periocular injections, again a post-op uveitis with CME, all sort of pan uveitis or refractory to systemic treatment. Again, sorry. This is again again after putting a betadine drop and a drop of local anesthetic, the patient is asked to focus in the microscope light, and just the preferred site is maybe inferior-temporal quadrant or a superior-temporal quadrant. So depending upon the phakic status of the patient, you have to inject at 3.5 or 4 mm or in pseudophakic 3 mm from the limbus, and again with a gentle rotatory maybe movement of the needle, you have to enter inside the eye, and when you reach the hub of the then you just inject, and you can see the transretinal going inside the eye, and just give a gentle pressure with a cotton bud for maybe 10-15 seconds, and then finally a drop of antibiotic. And if after the injection you feel that there is a globe is tense, then you can just do a paracentesis with a 26 gauge needle, or maybe with a insulin needle with the plunger out. So again, the complications could be mainly with the repeat injections, if there could be a rise in IOP in 25 to 40% in cataract progression. Then there is an incidence of infections and endophthalmitis also reported in 0.5 to 0.8% cases. There is also could be especially in patients of if there is a peripheral iridotomy, or you have pseudophakic patients or aphakic, there could be a migration of the particles into the anterior chamber, which is wrongly taken as endophthalmitis, and there could be remote chances of intravitreal hemorrhage or retinal detachment. Now coming on to the depot corticosteroid injection, this is which is US FDA approved for non-infectious uveitis. So this is a 700 microgram biodegradable dexamethasone intravitreal implant. This is the video by the company itself. So in this again, this implant is usually given, this is a applicator of the implant, it is a pen filled with the implant, and this is the actuator button, and this is the safety guard. So first of all you have to take out the safety guard, and then again in the inferior temporal or the temporal area you have to, with the bevel up of the applicator, you have to go slightly oblique till the hub is reached, and then you have to go directly into the vitreous cavity, and once you are there inside, then you have to click this actuator button. And the implant is released, and then but you have to take out the applicator, the needle, only when you have that there is an audible click which confirms that the implant is already into the vitreous cavity. So again you have to follow the patient for any IOP rise or endophthalmitis, and counsel the patient for if there is any sign and symptoms of any endophthalmitis. The patient has to report immediately. Normally the patient is seen the next day and then maybe a week. The chances of IOP rise are maximum between 4 to 8 weeks after the injection. Now some of the patients, like this patient was having an intermediate uveitis in left eye for 4 years. He was operated for complicated cataract, was given an off and on course of prolonged oral steroids, developed hypertension, diabetes. So he was given an option of intravitreal Ozurdex. You can see on presentation he had this media haze, vitritis and cystoid macular edema. And then 1 week after the injection, the vitritis is decreasing, the CME is decreased, and 1 month down the line there is no CME. Vision has also improved, media is clear. 3 months again there is no CME, 6 months no CME, but the Ozurdex, with Ozurdex also, though it is claimed that the CME or the edema doesn't come back by 6 months, but in our experience usually it comes back by 4 months, so you need to give a repeat injection. This is a 21-year-old female who was a case of inflammatory branch retinal vein occlusion secondary to the intraocular tuberculosis. She was started on ATT with oral steroids, but she was not tolerating steroids well. So first we gave her in a shot of intravitreal bevacizumab for the cystoid macular edema. But till 1 month the injection, there was not much relief in the macular edema. There was no resolution. So we talked to the patient and then we injected Ozurdex. And so post Ozurdex, the edema subsided. But at 4 months again, it came back. So we gave a second injection. And we did a repeat angiogram and did the laser of the CNP areas. So this is the last follow-up of this patient when the ATT was withdrawn and there was no macular edema with 6/6 vision. So Ozurdex can also be used as an adjunct in cataract surgery in patients of uveitis. This is a 7-year-old female with left eye chronic anterior uveitis with hypotony. The UBM showed normal ciliary processes, so we did a phaco plus IL with Ozurdex injection, plus she was on injection methotrexate for the systemic control. So we can see post-op the IOP increase up to 10 millimeters of mercury, and this was immediately post-op picture, the media haze, though there was no CME, and this is the last follow-up, there was good media clarity and again no CME. And so this child was not given systemic steroids, hence we could avoid the side effects. So another girl, 10-year-old girl with right eye idiopathic diffuse vasculitis. She was again given intravitreal Ozurdex, but in children, sometimes we have to be careful because they have low scleral rigidity. So, and when you give this injection, sometimes they may develop sudden hypotony. So especially in children, you have to be careful. Like in this case, she had developed this hypotonic maculopathy. All we did was wait and watch, and by 4 weeks, though her IOP rather became on a higher side, but her inflammation was gone. And this is 4 months. We gave a second injection also, and obviously in such patients you have to, if you can avoid giving systemic steroids, but you have to generally keep them on systemic immunosuppression. It can't be a substitute of the immunosuppression. So this is another, we were the first to publish that Ozurdex implants, if given in aphakic eyes, post-lancectomy, vitrectomy eyes, they initially they will definitely decrease the inflammation, they will resolve the macular edema, but after a period of week or 2 or 3 weeks, the implant may wander between the vitreous cavity and the anterior chamber and may come into the anterior chamber, can cause high IOP, can cause corneal edema. So one should avoid these implants in aphakic eyes. Though, so just slide on the other intravitreal options. Intravitreal anti-VEGF can also be given in uveitis patients. Mainly they are given in patients, those who already have healed uveitis, but they have some complications like an inflammatory neovascular membrane, or they have NVEs which are likely to bleed. They are normally not given in inflammation because they are very short acting and they are not very much helpful in decreasing the macular edema. Other options are intravitreal methotrexate, which is mainly treatment for biopsy proven primary vitreoretinal lymphoma, sometimes can be given in refractory cases of other non-infectious uveitis, and ganciclovir is usually reserved for CMV retinitis. So the take home message is steroids, if you are giving as a first line of treatment, you should be sure that you are dealing with non-infectious uveitis on a detailed patient history, examination, targeted investigations and imaging. If you are planning to give it as an adjunct in an infectious cause, you have to treat the cause first with appropriate antibiotic in cases like it is in tuberculosis or antiviral or an antifungal or an antiparasitic, like if you're dealing with cystic circus. Local steroid therapy can provide good control of inflammation and stabilization of vision, but it has invasive nature and it needs to be repeated. One should monitor for adverse events. Thank you.
Thank you, Dr. Pooja. For short of time, we'll take questions later. Thank you so much. Good morning. I'll be speaking on cataract surgery in uveitis. Can you switch it on? Thank you. So cataract surgery in uveitis is more common because of the uveitis steroid, or if the patient had associated surgery like TRAB and vitrectomy. The outcomes depend on the comorbidities, and the type of surgery you are planning. And the comorbidities, whether it's anterior uveitis, intermediate or posterior, and worse in children. The principles of surgery is that the uveitis should be controlled for more than 3 months. Is changing itself. Control is not there. It should be controlled for at least 2 years in GIA, and always remember that you need to give peri-operative anti-inflammatory, whether oral steroids, or you can give even 3 months of DMARDs before you plan the surgery, because the main aim is to prevent the macular edema. Intra-operatively, you can have a shallow AC, a posterior synechia is causing problem, pupillary membrane, no glow, small pupil, and you need to do capsular scaling, and sometimes you have a calcified capsule or zonular dialysis. The removal of the pupillary membrane is important. You can use viscodissection of a focal synechia, minimize the iris trauma, prefer to stretch than to use hooks and expanders, and avoid a sphincterotomy. If you have a total posterior synechia, you can do a PI and then separate out the iris. This is the patient of... What's happening here? So this is a patient, bilateral intermediate uveitis was not controlled. I gave the patient methotrexate, biological, still the uveitis were not controlled, and I had to give an intravitreal triamcinolone before the surgery. Remember, in children it is intumescent and the rhexis can run peripherally. You need to separate the synechia. The rhexis visualization is difficult, and sometimes it can run off. And in children, you don't want to put a sulcus lens or a AC or a scleral fixated because they have severe uveitis. So the pressure on you to have a in the bag lens is very important in children. So whether this patient had also had vitreous opacities, the aim was whether one should do a combined vitrectomy with it. I plan to do a separate one. Now this patient is almost 2 years on treatment, has 6/18 vision and 6/6 vision, and still has vitreous membranes. So sometimes you feel the need for a vitrectomy also. So in a child, the IA is easier. You can just use a bimanual IA. You don't need to make an incision in the beginning for the IOL implant. So the AC is well formed. Then you can enlarge the wound later to put in the IOL. So the most important thing is keeping the pupil mobile, preventing posterior synechia, control the uveitis well pre-operatively, and also post-operatively to prevent the macular edema. Normally in children, you would like to do a capsulotomy or a shared vitrectomy at the time of surgery. In GI, it is a controversial topic whether you should put IOLs, generally 1 year off medication with more than 2 years control, no cyclitic membranes on the UBM, avoiding hypotony, and if the patient has posterior synechia, you will have poor results, and which happened in one of my case where I had to explant. My rheumatologist kept saying, now that we are on biologicals, do try IOLs, and this patient developed such a severe synechia, poor vision, that I had to explant the lens. So the patient had hypotony. It was difficult first entering the chamber. So when you have a small pupil, it's difficult to prolapse. You just rotate the lens into the interior chamber so the loops come out. So you can either cut it, but the hypotony was so severe, and the more so I planned to put an infusion cannula to increase the pressure. I thought I may have to do a vitrectomy. The vitreous membranes are too high. So I changed mid-course to do a vitrectomy, enlarged the incision. I didn't want to use so I just used a Clayman forceps and took out the lens. So remember that these complications affect the surgery, the PCO, the CME, epiretinal membranes, RD, hypotony, vitreous hemorrhage, and CNVM. So you must anticipate. It may look to you that the patient has a mild uveitis, and the post-op results are not guided by your surgical technique, but more by what the complications which are there. Thank you so much.
Thank you, Dr. Amit. Now I'll call Dr. Reema for her talk on diagnostic vitrectomy and retinal choroidal biopsy.
Do we have a pointer? Pointer. Okay. So, very good morning, all of you, and thank you for being here in the morning session. And thanks, Dr. Amit and Pooja, for this invitation for me to talk on diagnostic vitrectomy in uveitis. So, it was the first time in 1979 that the usefulness of pars plana vitrectomy and lensectomy was reported in patients with uveitis. Basically, they postulated that removing just the vitreous gel alone was therapeutic in uveitis. And following this, there were lots of publications on 20 gauge and then later on microincision vitreous surgery. So coming to the diagnostic indications of vitrectomy in uveitis, any intermediate, posterior or panuveitis of unknown or suspected origin where conventional methods, that is your clinical assessment and laboratory investigations, have failed to give you any diagnosis. Where you are strongly suspecting an intraocular malignancy. Third is a potentially sight-threatening acute uveitis with a negative non-invasive initial workup and ancillary investigations. And whenever we have an atypical presentation of uveitis, we are tempted to go for a diagnostic vitrectomy. So the preoperative preparation is important in these patients in terms of we have to have a very detailed clinical history, complete ocular examination as well as general physical examination, and of course relevant ancillary and laboratory tests before we take up the patient for vitrectomy. Now once we decide that we are going to operate this patient for diagnostic vitrectomy, we have to have certain differentials in mind because we need to order accordingly what we are looking for. So you have to have a clear plan by the uveitis expert about what tests to be done on the vitreous samples. And since the main aim is to subject the sample for diagnostic tests, we must inform the microbiologist and the pathologist before taking up the patient for surgery, so that their laboratory is ready to receive and process the samples. And we need to take utmost care to transport these samples to the concerned laboratory as soon as possible and of course under optimal conditions so that the cells don't degenerate. And one important thing is because our microbiologists and pathologists are usually used to handling samples like blood and serum and urine which can be reproduced anytime, so they're not very sensitive to the vitreous sample. So we have to make them realize that this is the only time we are going to get this sample from this patient and never repeat itself. So we have to be very careful in treating these samples as extremely precious samples. Of course, a written informed consent from the patient about the nature of the surgery and the likely complications. And the most important to tell to the patient is that there is very high likelihood of having no definitive results in the reports, because when you take up the patient for surgery, we have to tell that we are taking up for surgery, but we are likely not to have any positive results. But if we have, we are quite lucky. So the various tests that we perform on these vitreous samples are the molecular tests, that is the PCR tests, cytology, smear culture for any infective etiology, immunohistochemistry and flow cytometry for any malignancy, cytokine level analysis, and which are all tailored to the patient profile. So the sample collection and transport is very critical. This is just the tubing that is used to connect to your ports of vitrectomy and the syringe which takes the sample. And once the sample is taken, you label it accordingly, appropriately, and then hand it over to your microbiologist and pathologist and the laboratory. So this is the ideal setup, the general principles to be followed when we prepare these trolleys for under extreme aseptic precautions. You can see the microincision trocars and cannulas. Now just an important word of precaution, something wrong in the slide, in the picture on the right, which is just take care that all your syringes are not filled with air. Try to keep them without air, because once you're attaching the tubing or the syringe to the tubing, your assistant is likely to inject if it is already containing air. So it makes your surgery messy and can do harm. So make sure that your syringe is completely without any air. So we nowadays in the era of microincision vitreous surgery, we routinely perform the standard 25 or 27 gauge About 0.1 ml, that is 100 microliters of undiluted vitreous sample can be collected without any damage to the eye, followed by about 4 ml of diluted vitreous sample, which is collected manually under direct visualization in sterile syringes attached to the aspiration line of the vitreous cutter, and then transported to laboratory in cold chain. The samples are immediately transferred to the microcentrifuge tubes, and they are divided there for diagnostic and research purposes. So this is the complete cleaning, draping of the patient, and the surgeon is ready to collect the samples. You can see the tubing is attached to the aspiration line of the vitreous cutter. The assistant starts aspirating the syringe once the vitrectomy is started. And this should be done in complete light of the OR. It's better to keep the lights on rather because the assistant can see actually how much of the fluid is being aspirated. Similarly, you can take about 3 to 4 syringes like this and then label them with the patient's name, the date of sample collection, the surgeon who's asking for it, and whatever tests you want. And of course, which syringe contains the undiluted and the diluted fluid. This is how we collect the undiluted sample under air. So instead, once you attach your infusion cannula, we don't put on the infusion fluid, we just keep it under air because you are collecting the undiluted vitreous fluid. So once you start the vitrectomy, you can see the little amount of air bubble, and once you start the vitrectomy, the air starts replacing the part wherever the vitreous is cut. And up to 100 microliters is safe, and you can see the eye becoming soft, and that's the time when you're done with your vitreous undiluted sample, and then you put on the infusion fluid. So you can now see that after completing your undiluted vitrectomy, so remove the ports and make sure that they're not leaking. Now, a few concepts about the vitrectomy parameters. Some surgeons prefer a high cut rate, the normal cut rate, and some surgeons prefer low. Simple reasons is at a fixed flow rate, the higher the cut rate, the smaller the bite size. So, and lesser amount of vitreous is aspirated into the cutter for any one cut. But if the cut rate is low, that is when we keep it at about 1000 or 2000 cuts per minute, the bite size is larger and it increases the vitreous yield. So some surgeons prefer this. The surgeons who prefer high cut rate is to reduce the tractional complications, which are a major concern in uveitis. But the low cut rate increases the traction on vitreous and retina. So it's the surgeon's choice what cut rate you want to use. So the port closure, if it is not leaking, it's okay, you can leave it like that. But if you have a slightest of doubt, you can suture the ports. So diagnostic vitrectomy can be a core vitrectomy, which is known as the vitreous biopsy, or sometimes with posterior hyaloid removal. We usually advise against inducing the PVD and then subretinal biopsy. So this is an example where core vitrectomy is required. An elderly gentleman presenting with bilateral severe vitritis. You can see the amount of vitritis, lots of vitreous membranes, not possible to do a fluorescein or an OCT. So we could not even put this patient into any anatomical classification. So we took up this patient, was counseled, and the main suspicion was intraocular malignancy, and the report was non-Hodgkin's B-cell lymphoma. Even the IL-10 ratio was high as compared to the IL-6. Can I take a few minutes? Yes. Thanks. So this led to the MRI, which later on revealed the CNS involvement. So this patient was not aware of any CNS symptoms. He didn't have one. So this turned out to be an intraocular lymphoma with CNS lymphoma. I want to highlight this young girl who presented with dense panuveitis in one eye, in the right eye, and she had a lot of vitreous haze. We could not really see the fundus. The only good thing about her was she had a necrotic Montaux. But on the basis of this, the pulmonologists were not ready to administer ATT. We took her up for a diagnostic vitrectomy. And intra-op, we found that there were a lot of patches of focal vasculitis inferiorly, along with infiltrates along the vessels. So this examination was not possible pre-op because of the dense vitritis. So we can see there are a lot of exudates on the retinal surface. These were all along the retinal vessels. So although her labs were all negative on the vitreous samples, Because of the intra-op findings, we had a diagnosis of TB in our mind, but again, because the pulmonologists were not ready to start the ATT, we did not. However, 4 months later, she developed few pulmonary symptoms for which CT chest was repeated by the pulmonologist this time, and then they labeled this patient as tuberculosis. So this case tells us that diagnostic vitrectomy not only helps you for the diagnostic tests, but tells you about certain intra-op findings which give you an important clue towards the etiology of the condition. So core vitrectomy, diagnostic and therapeutic, is of course indicated in endogenous endophthalmitis, where you can have septate hyphae demonstrating a fungal infection. So this is how it helps. Just a core vitrectomy, the exudates start resolving once you debulk the vitreous, and this is the complete resolution at 11 days. The culture also grew aspergillus. So this is an important case where we induced PVD induction. Normally we don't do it. This was a case with a focal lesion on the fovea. You can see the entire retina is involved. So because the patient was already a known case of swine flu, we thought it's an influenza retinitis. We started steroids, but at 5 days you can see the patient worsened. And the OCT also showed a horizontal spread of the exudates. So they were all on the surface of the posterior hyaloid and on the retinal surface. So what we did was, because vitritis was minimal, we just took up this patient for vitrectomy, followed by we removed the hyaloid and removed the exudates on the surface of the retina from the fovea. We are aspirating these exudates on the retinal surface. You can see the hyaloid being cut here. So it was these exudates that actually demonstrated that there was a fungal infection. So all the tests corresponding to fungus were positive. So this was actually a case that started as fungal chorioretinitis without vitreous traction. Without vitreous invasion, if you go through the stages of endogenous endophthalmitis, and our steroids converted into a fungal chorioretinitis with vitreous invasion, and our vitrectomy actually led to control of infection in terms of removal of the posterior hyaloid and the exudate sitting on the retinal surface. Coming to the subretinal biopsy, it's indicated in where you see subretinal deposits. So it's a rarer form of diagnostic vitrectomy that we do. Highly invasive should be done only by an expert vitreoretinal surgeon, and you have to have your pathologist available. It's a must. It can be through an external or an internal approach. The internal one is more common. This is by routine PPV followed by the aspiration of the subretinal fluid, because the lymphoma cells are quite friable and they're very soft, so you can easily aspirate them into your soft tip and then perform a laser around the site of biopsy followed by an internal tamponade. The complications are expected to be choroidal hemorrhage, retinal detachment, and an inadequate sample. So development of cataract and the other things are minimized by the microincision vitreous surgery. And then we can have unusual IOP responses post-op, and we can take care of that. And these are all certain hemorrhagic choroidal detachment, retinal detachment, vitreous hemorrhage, and some of the known complications. So benefits of vitrectomy are not only diagnostic but also therapeutic. So microincision vitreous surgery is safe and efficacious and should be carefully planned in these patients. Clear plan by the ophthalmologist, and basically I would say it's a teamwork between the ophthalmologist, microbiologist, and your cytopathologist. Thank you very much.
Thank you, Dr. Reema, for your elaborate talk. Now I'll request Dr. Mudit Tyagi to come and speak on vitrectomy therapeutic in uveitis.
All right, so good morning, and first of all, let me thank the organizers, Dr. Amit and Dr. Pooja, for giving me the opportunity to talk in this instruction course. I will be speaking on surgeries in uveitis and the basics of that. Dr. Reema has already elaborated upon what are the diagnostic indications of vitrectomies in cases of uveitis, and we cannot undermine the importance or the advantage that a vitrectomy affords to us in these cases. Now, we will not go upon these, but the fact is that over a period of time, with the evolution of instruments and evolution of vitrectomy surgery as such, the surgery has become much more safer. From 20 gauge, we have now migrated to 23, 25, and even 27 gauge. And with the 0.5 or 0.4 millimeter entry into the eye with faster cut rates, we have got shorter operating times, faster recovery for our patients, and our techniques have become much more improved, lesser invasive, and afford much more of a manipulation inside the eye. Now, there have been already multiple papers which have shown the importance of a therapeutic vitrectomy in these eyes, where they have shown that removing even the load of antigens helps in regression of cystoid macular edema in many of these cases. But apart from these facts, apart from the fact that a vitrectomy affords to remove the vitreous opacities, gives us a clearer media, reduces the antigen load and helps in resolution of macular edema, there are certain other indications over here. And those are some which are very peculiar to uveitic cases. These behave differently from an otherwise idiopathic case. So apparent membranes, detachments, diagnostic dilemmas can all occur in case of uveitis, and these are different to handle. RDs or detachments occur in a lot of cases of ARN and CMV in up to 3/4 of patients, and they can have both arachmatogenous and tractional component. Now, there are certain problems which are peculiar to uveitis cases. You have got a pre-existing retinitis, vitreous adhesions are abnormal and much more thicker. You have got thick ERMs, and you need to handle them with care. So let me just go through a few videos which highlight what are these problems which we face when we encounter these things. So, the videos are not playing. What's happening? Yeah. I think I will directly come to the videos, and that will save the time over here instead of this PowerPoint. There's something stuck with the video. So if you look at it, these eyes have got extensively thickened vitreous adhesions in the periphery, and if you look at all of those, these vitreous adhesions need to be tackled. Somehow the characteristics of vitreous in eyes with uveitis is much more different than what you see in a routine eye. This vitreous is much more thicker, there are a lot of opacities. It's probably got to do with more of interleukin expression over here. The ERMs are also extremely thickly adherent, and if you're not very careful, you'll end up causing a break. So you have to be very careful in removing these ERMs. Some of the ERMs, specifically in eyes with acute retinal necrosis or post a CMV or post a retinitis, even in eyes with toxo we have seen, these ERMs can be very thickly adherent, and you have to carefully remove them. Sometimes you might even need to truncate these ERMs. So you can use a scissor or a forceps to remove them. I'm sorry. So this was a thick ERM which we first of all removed after removing the hyaloid, and you can see it's so thick that I had to use a cutter over here to remove it. Apart from that, one more problem which you face is the peripheral necrotic retina. The retina in these cases is totally necrotic. You will see these multiple areas of or patches of necrosis and peripheral breaks, and these are the areas from which the detachment occurs. So you have to be careful while even you're doing a vitrectomy. If you try to induce a PVD or try to pull too much, you will end up creating more of breaks than what you otherwise would be hoping for. So be careful about the peripheral necrotic retina which you see over here, because that is something which you need to handle. You can truncate or shave your vitreous over here instead of doing anything else. When it comes to doing a laser in these cases, that is another problem. The fact is that your laser has to be done in eyes which in the area of healthy retina. And again, just I will like to highlight one more video of an ERM. So this is again was a patient with an extremely thick ERM. If you see over here, you have to be very gentle. Otherwise, what you'll do is you'll end up creating a break or even a macular hole. So the point over here is that in cases where you've got a surgical intervention, in cases of uveitis, you have to handle the vitreous a bit differently from what you as a retinal surgeon will do for routine cases. So these are the cases. This was how this patient was initially, and I'll just switch on back to the PPT. So this was how the vitreous was, and this was how the patient's eye was pre-operatively, and after you remove, the ERM settles down, the visual acuity also improves. So in conclusion, detachment surgeries in cases of viral retinitis are different. Vitreous adhesions, necrotic retina, and thick membranes need to be addressed properly. There is also a high risk of recurrences, and these eyes will require a long-term tamponade. So in the interest of time, I'll stop, and I would at this point of time also like to invite you for the next Uveitis Society of India conference in Hyderabad from 9th to 11th of October. Once again, thank you for being here early morning, and thanks to the organizers of this IC. Thanks a lot.
Thank you, Dr. Tyag. Any questions?
My question to Dr. Reema. Ma'am, these days are you doing just purely vitreous biopsy using the doing vitrectomy, or like earlier we used to do vitreous biopsies with a 26 gauge needle in the OPD or emergencies? Is that indicated anymore?
No, I think, Pooja, in the era of microincision vitreous surgery, just the vitreous aspiration is not recommended. We don't do it. So we simply just go for a good vitrectomy that helps for both diagnostic and therapeutic. So just aspirating, no, I think it has more of complications.
Thank you, Dr. Mujit. I thank the audience for a patient hearing. Thank you. Can we have a photograph?
इसको लगा दीजिए